All right, we'll go ahead and get started. Um, so hello and welcome. My name is Mac McCullough. I'm faculty here at the BSU School of Public and Population Health, and I'll be moderating today's session. Today is the second session in the BSU School of Public and Population Health's inaugural continuing education series. We are delighted that you're able to join us today and are excited about being able to offer these sessions to help support the work of Idaho's public and population health workforce. So as I mentioned, this is only our second session of this series, so we are still learning how to best meet your needs. So you'll be receiving a feedback survey shortly after today's presentation. We would greatly appreciate any feedback you have for us, positive or negative. Our goal is to make these sessions informative, interesting, and valuable for you, so your feedback is much appreciated. Before we begin, a couple of housekeeping items. Please keep your microphone on mute during the presentation today, except when you're coming off to ask a question. This session will be recorded and made available after the conclusion of the session. Please feel free to drop questions into the chat at any point during the presentation. I'll be monitoring, and we'll have a Q&A session towards the end of our time today. And if it's something urgent or sort of clarifying on a slide, I'll jump in and ask the presenter. If you encounter any technical issues during the session today, please feel free to let me or Brian Young know, and we'll do our best to resolve it. So without any further ado, I'm delighted to be able to introduce today's presenter. Dr. Desmond Banks is Clinical Assistant Professor at the BSU School of Public and Population Health. He has a strong background in research, evaluation, and care coordination among disadvantaged populations. And today he's going to be talking about our changing behavioral healthcare system, trends in policies and activities. So Desmond, please take it away.
Thank you very much, Mac, and good afternoon, everyone. Thank you very much for joining. Mac, is my audio coming in okay, and my screen sharing is coming in pretty good?
Yes, we're hearing you and seeing your screen.
Excellent, excellent. I'm going to turn off my video in order to conserve network connectivity capabilities, but I will turn it on later on during the question answer. So again, good afternoon. Welcome to our second session on our changing healthcare systems, healthcare system trends and policies and activities. I'm Desmond Banks, as Mac stated, clinical assistant professor within the Boise State University School of Population Health. All right. So our agenda for today is going to be threefold. We're going to discuss three things. We're going to first examine what is behavioral health. Second, we're going to explore current trends in behavioral health. And third, we're going to examine how we can actually use this information presented today. Excuse me. So what is behavioral health? Behavioral health generally refers to mental health and substance use disorders, life stressors and crises, and stress-related physical symptoms. This definition here comes from the American Medical Association. All right. I've highlighted life stressors and crises here, just to kind of bring this home to everyone. A lot of times when we talk about behavioral health, there's an emphasis on what I would say, such as schizophrenia and other genetic conditions. But when we, it also encompasses life stresses and crises. And just to bring this home, something relevant for all of us, the COVID-19 pandemic that we just looked at, that we examined. Here's a recent excerpt from one of CDC, their morbidity and mortality weekly report that was published several years ago during the pandemic. They actually examined mental health, substance use, and suicidal ideation during the COVID-19 pandemic. And the quote from the report here is that elevated levels of adverse mental health conditions, substance use, and suicidal ideation were reported by adults in the United States in June 2020, the height of the pandemic. The prevalence of symptoms of anxiety disorder was approximately 3 times those reported in the second quarter of 2019, or just before the pandemic, of about 25.5% versus 8.1%. And the prevalence of depressive disorder was approximately 4 times that reported in the second quarter of 2019. So here's just a report and data that shows the impact that life stressors and crises can have on mental health. So it just encompasses that entire definition, this entire span of behavioral health. Okay. So what are some of the current trends in behavioral health? All right. One of the key kind of overriding trends in behavioral health has been this concept of what's known as intersectionality. All right. intersectionality. And this is a term that was actually coined by Miss Kimberly Crenshaw, who's currently at Columbia Law School. And as you see here outside the realm of public health, but this was coined by Kimberly actually many, many years ago in the volume, and this great work, Demarginalizing the Intersection of Race and Sex, a Black feminist critique of anti-discrimination doctrine, feminist theory, and anti-racist politics. Those are some of the words that we've heard contemporarily, these terms within the past several years, but actually this was published 25 years ago, nearly 25 years ago by Kimberly here. But this term is now being applied, moved outside of the legal realm and actually being applied to public health. And within this report, this article here, she states the following in describing intersectionality. Consider an analogy to traffic in an intersection, coming and going in all four directions. Discrimination, like traffic through an intersection, may flow in one direction and it may flow in another. If an accident happens in an intersection, it can be caused by cars traveling from any number of directions and sometimes from all of them. Similarly, if a Black woman is harmed because she is in an intersection, her injury could result from sex discrimination, race discrimination. All right. So what you're seeing here is Ms. Crenshaw's kind of conceptualization of intersectionality here about 24 years ago. The intersections of race, all right, being Black, and also of gender, right, that combined experience of race and gender and how they could produce experiences that are different from either of those demarcations alone. All right. And contemporarily, this term is, as I mentioned, has been picked up and being applied to behavioral health and public health in general. Here's a definition from the National Alliance on Mental Illness. And you can see here from the graphic, when we talk about intersectionality, we're talking about a multifaceted kind of just, display or cadre of elements that make up who we are, right? That define us as human beings. We have gender, race, ethnicity, class. Quick quotes. Mac, can you see my arrow on the screen? Is that coming through?
Yeah, it's pretty small, but yeah, it's right up there by class.
Got it. Thanks, Mac. So you see, gender, race, ethnicity, class, nationality, sexual orientation, abilities, just some of these overlapping spheres that of the criteria that define who we are as human beings. And I'm going to read this excerpt here from NAMI. Intersectionality encompasses the idea that we have more than one identity with a combination of various identity markers such as gender, race, religion, sexuality, etc. These identity markers intersect with one another and shape our experience. This pertains to mental health because our mental health oftentimes does not exist separately from identity markers. Mental health can be impacted by gender, sexuality, age, religion, and more. There may be unique life stressors that accompany these identity markers, as we saw with the previous data on COVID. An example of this is that a queer individual may have unique stressors related to their sexual identity that heterosexual people may not experience. When having conversations about mental health, including a wide range of narratives on inequality, discrimination, erasure, and violence that marginalized individuals experience, are important because they impact mental health outcomes. However, it is important to understand that our individual identities are not the issue. The problem lies within power systems that cause discrimination and oppression. I'm going to read that again. It is important to understand that our individual identities are not the issue. The problem lies within power systems that cause discrimination and oppression. These power systems can impact mental health outcomes. Again, this is from the National Alliance on Mental Illness, or NAMI. Okay. As being, researchers and academics, we always ask questions, right? That's part of our job. So you see here is this last excerpt highlighted in yellow. I'll put it here within this next slide. It says the problem lies within power systems that cause discrimination and oppression. These power systems can impact mental health outcomes. All right. So I want to use these three questions here to guide the rest of our presentation today. Okay. We're actually going to explore, can discrimination and oppression impact mental health outcomes? All right. We're going to test to see if this statement here from NAMI is true or just explored. And if it's true, if so, how much impact do they have? All right. second question. Third, we're going to examine how much does intersectionality influence the impact of discrimination and oppression? All right. So again, three questions. We're going to explore, can discrimination and oppression impact mental health outcomes, as stated here by Nami? And if so, how much do they? How much impact do they have? How much impact do discrimination and oppression have on mental health outcomes? And third and finally, we're going to explore how much does intersectionality, if at all, influence the impact of discrimination and oppression? All right. So let's examine this first question. Can discrimination and oppression impact mental health outcomes? All right. To answer this question, we're going to go look at a recent release from what we know as the Substance Abuse and Mental Health Service Administration, or SAMHSA. As you can see right here from the title, SAMHSA releases new data on lesbian, gay, and bisexual behavior. And this topics of this discussion is current trends, and this is fairly current. This is just of June this year. All right, about 5 months ago. All right. You can put this within your search engines and just put up, SAMHSA LGBT report, and you'll take you right to the URL there. We'll also share the slides, which will be within the URL there as well. But as we can see right here from the title page, it states, the Substance Abuse and Mental Health Services Administration, SAMHSA, today released a new data report, Lesbian, Gay, and Bisexual Behavioral Health, results from the 2021 and 2022 national surveys on drug use and health. And the report is available for download, indicating that lesbian, gay, and bisexual adults are more likely than straight adults to use substances, experience mental health conditions, including major depressive episodes, and experience serious thoughts of suicide. Again, SAMHSA released a report indicating that lesbian, gay, and bisexual adults are more likely than straight adults to use substances, experience mental health conditions, including major depressive episodes, and experience serious thoughts of suicide. Here's a quote from one of the authors. We know that statistically, lesbian, gay, and bisexual Americans face increased risk for mental health and substance use issues, which is often related to stress caused by stigma, discrimination, and harassment. And this is from HHS Assistant Secretary for Mental Health and Substance Use, Ms. Miriam E. Delphin-Rittman, and the leader of SAMHSA. All right. So for those of you who don't know, SAMHSA is the leading regulatory authority within the United States concerning substance use and mental health. And so based upon their findings, we can, just kind of, I don't want to say take their word for it, but we can, pretty much mark this as a yes. Can discrimination and oppression impact mental health outcomes? Well, if SAMHSA says so, then I'm give a fair amount of confidence that is true. All right. But well, let's just say we give them a pass, say yes. If so, how much? All right. How much impact does discrimination and oppression have on mental health outcomes? All right. Let's explore this question. All right. And looking and examining this question, we're actually going to look to the report, all right, that SAMHSA was referring to. So when you click on this website, you download that PDF. Here it is right here. All right. They'll take it to the title page, Lesbian, Gay, and Bisexual Behavioral Health. Results from the 2021 and 2022 national surveys on drug use and health. So the most current behavioral health data that we have available today. All right. And within this report, you'll see many different infographics. All right. Starting off with this one. All right. Give folks just a few seconds to become acclimated with this. All right. So we're just there's a lot of data here. There's a lot of different terminology. So we're going to walk through it. We're going to walk through it together. All right. First, we're going to look at alcohol use. All right. And this is the percentage using within the past month. All right. So this is what we're referring to. Alcohol use percentage using in the past month. All right. So this any alcohol use. All right. Any alcohol use within the past month. All right, we're going to follow the arrows. All right, what is the next arrow take us to? Okay, we're going to look among females. All right, so any alcohol use, okay, within the past month among females. Let's look at sexual identity, bisexual. All right, and as you can see here, we have gender categories. right? Male and female, we all also have sexual orientation categories. Among women, among females, we have lesbian, bisexual, straight. Among males, we have gay, bisexual, and straight. All right. And so it'll be broken down through this way throughout the next several images that we look at. So we'll look among bisexuals. What we can see from this chart is that 59.3%, all right, nearly 60% of bisexual females have reported alcohol use within the past month. All right. I'm just walking through how to read these slides. There's a lot of numbers, a lot of data here. So any alcohol use, 59.3%, nearly 60% of bisexual females had any alcohol use within the past month. All right. Compared to straight females, all right, going back down to the female category, heterosexual straight females, 49.6%. All right, so we can see from this data here that about 10 percentage points higher for bisexual females compared to straight females. We can say what one might call a higher risk or a higher likelihood of alcohol use among bisexual females compared to straight females. All right, let's look among men. Okay, let's look among men. Again, we're looking at alcohol use within the past month, any alcohol use. Let's look among gay men. Okay, we see here it's the highest category, 65%. 65% of gay men reported using alcohol within the past month, compared to the lowest within these stratifications here, straight men. All right, again, about 10 percentage points higher. All right, so gay men had on average about 10% higher points, 65% of gay men compared to 55% of straight men using alcohol within the past month. All right. And just looking at this data in totality, we say any alcohol use, we see that for both among men and women, among males and females, sexual minorities, what we call it, particularly among females, bisexual females were about 10% higher of using alcohol within the past month, whereas among men, gay men had the highest rate of alcohol use. But even among women, it was still higher among the lesbian categories, and also men among bisexuals. But overall, sexual minorities had higher rates of alcohol use. All right. Another facet here, we're going to look at binge drinking. All right. And I know this text is a little small, so I can read it here. Binge drinking means consumption of 4 or more drinks on the same occasion for females. All right. So among females, it's consumption of 4 or more drinks on the same occasion, and 5 or more drinks on the same occasion for males, at least one day in the past 30 days. All right, so read this again. Among binge drinking means consumption of 4 or more drinks on the same occasion, so on the same night or afternoon for females, or 5 or more drinks on the same occasion, same night or afternoon for males, at least one day within the past 30 days. All right, that's binge drinking. Now, heavy drinking, okay, heavy drinking means binge drinking on 5 or more days within the past 30 days. All right, so we look at binge drinking, 4 to 5 drinks at the same time within the past month. But heavy drinking means, okay, you're binge drinking on 5 or more days within the past month. All right, that's what orients us to some of the data that we're looking at. So this is what we're looking at here: heavy drinking, heavy alcohol use. All right, previously we looked at any alcohol use. Now we're looking at heavy alcohol use. We can see back among females that among lesbian females, 10%, 10.9%, 11% specifically, 10.9% reported heavy alcohol use. All right, with binge drinking on 5 or more days in the past 30 days. All right, 10.9% of lesbian women binge drink 5 or more days within the past 30 days, compared to just straight women, just 4.4%. All right. So over twice as likely, over twice as many, there are over twice as lesbians had nearly 3 times. If you look at 2.5 times more likely to report heavy alcohol use compared to the straight. All right. So, and what we see that even though what we see here is that sexual minorities, both lesbians and bisexuals, their rates of heavy alcohol use much higher. All right, over twice as much, whether lesbian category specifically or bisexual alone, much higher than the straight category. All right. Let's look among males. Well, we don't see those same differences among men. All right. Those the rates are relatively the same. Roughly percent of heavy alcohol use. All right. So what we see here among women, we see different rates among sexual minorities. We didn't see the same pattern among male. Okay. All right. So now we've become kind of oriented with our categories here. We have our gender and sexual orientation categories. We're going to look at illicit drug use. Okay. Just give ourselves a few moments to get acclimated to the slides here. Illicit substance use, illicit drug use. All right. So again, so this is percentage using within the past year. This previous slide, we looked at alcohol use as percentage using within the past month. Now we're looking within the past year. All right. Percentage using within the past year. Again, we're going to go back to any illicit drug use. Any, this is shaded in the purple here. Any illicit drug use, starting here among females. Bisexual females, we see that nearly half, 49.7%. Okay, 49.7%, roughly half of bisexual females report illicit drug use within the past year. Nearly half, 49.7%. Juxtaposed, all right, juxtapose that against straight women, 20%. 20%, all right, half versus 1 in 5. We see significant differences, significant disparities by sexual orientation among women as regarding any illicit substance use within the past year. Okay, let's look among men. And we see a similar pattern. Roughly half of bisexual men, 49.5% specifically. All right, compared to just 26.7% of straight men. All right, nearly twice as many bisexual men using illicit drugs within the past year compared to straight men. All right. And we look across genders, we see similar patterns that bisexuals compared to straight, nearly twice as likely. We also see similar rates among lesbian gay categories. And we juxtapose this to our previous um, findings on alcohol consumption. Sorry about the looking for where we didn't see that. We just saw that just among females, right? But a heavy alcohol use, it was static, pretty much consistent across sexual identity. When we look at substance use, we see that sexual minorities for both men and women, all right, much, much, much higher rates of past year illicit substance use among sexual minorities compared to straight persons. All right. Now let's look at marijuana use. All right. And as you can see these findings there, for those who've been examining, I've been speaking, we can see that any illicit drug use is being driven by cannabis, by marijuana, THC, whatever terminology you want to use, that the vast majority is, marijuana use. All right. And with I will say the evolving legal landscape with cannabis, um, I'm trying to read your things, read the comments in the chat here. Yes, interesting. The transgender and sexual is not mentioned in the most recent SAMHSA information. Great point, Dana. Hopefully we'll get a chance to explore this further towards the end. I just want to make sure that I don't have anything pressing. Yes, absolutely, right. So with great comments, guys. You guys are reading right along. But you'll see here that any illicit drug use is being driven by cannabis use, right? And so there's, I would say it's because of the evolving legal and social landscape with marijuana. It's important to, interpret those cautiously. All right. Again, illicit past year drug use, but when you look at illicit drug use other than marijuana, all right, drugs that have not fallen within the same legal and social um, context with it, cannabis is faced. We see patterns, right? But let's look at illicit drug use. All right. illicit drug use other than marijuana. So taking marijuana out of picture, taking the social and legal concept of, that marijuana has been engaged in the past, we're taking that out of the picture. All right. So inclusive use of marijuana. We are talking about cocaine, heroin, hallucinogens, inhalants, and methamphetamine, as well as the misuse of prescription drugs. All right. Pain relievers, tranquilizers, stimulants, or sedatives. So when we look at illicit drug use outside of marijuana, other marijuana, we're talking about some hardcore drugs, cocaine, heroin, and others. All right. So looking at, and that's this blue category here, oriented to the colors. Through other marijuana, taking marijuana out of the context, all the social exceptions and legalization, taking it out of the picture, we still see striking disparities. Misuse of prescription drugs, we have definition means use in any way not directed by a doctor, such as use without a prescription of one's own, or use in greater amounts more often and longer than told to take a drug. So illicit drug use and misuse of prescription drugs. All right, that's what we're talking about here. We look among females, 20%, 1 out of 5 bisexual females report illicit drug use within the past year. All right. Whether it's cocaine, heroin, misuse of prescription drugs, 20%, 1 out of 5, compared to just 6.7% of straight females. All right. Roughly 3 times as much. All right. Roughly 3 times as many bisexual women report using hardcore illicit drugs compared to straight women. All right. Let's look among men. Similar patterns. All right. Over 25%, 26.7% specifically, more than 1 in 4 bisexual men report illicit drug use other than marijuana, including cocaine, heroin, hallucinogens, misuse of prescription pain medications, to 10%. All right. 9.7% of straight men, almost 3 times as many. All right. Looking at the intersections of sexuality here. All right. And we see similar patterns among lesbian and gays, but the highest category among bisexuals here, and it's across both genders. Okay. Similar to what we saw with any substance use across both genders, that bisexual and sexual minorities are much more likely to use illicit drugs compared to straight persons. All right. And again, looking at these categories together, what we call sexual minorities, lesbian, and bisexuals, there are differences between, right? The bisexuals have a higher risk, 1 out of 5, whereas with 13.8% of lesbians. All right. So even across these gender identity, between gender identities, between sexual minorities and straights, but even within sexual minorities, we see differences in illicit drugs use for females and less so for men. All right, the difference was a little bit higher for this one among females than compared to men, but still within sexual minorities we see differences. All right, compared to straight persons. All right, both men and women. Look at those categories. But then we see between genders a little bit higher among men for illicit substance use, but the overall patterns definitely sexual minorities, whether it's male or female, much higher rates of illicit drugs use within the past year. All right, so going back to our second question. All right, again, gonna go like that. The problem lies within power systems that cause discrimination and oppression. These power systems can impact mental health. So we had a yes for this person. We looked at discrimination and oppression can impact mental health. If so, how much impact do they have? Well, just looking back at alcohol use, we see that sexual minorities were over twice as likely for heavy drinking, which means binge drinking on 5 or more days, at least 5 days, could be more than 5 or more days for the past 30 days. All right, we see both of these figures much higher than straight persons, so over twice as likely among whether you're lesbian or bisexual for females, much likely was heavy alcohol use. All right, and we saw that for illicit substances for men, and women. Sexual minorities had much higher rates compared to straight persons. So I think that we can action that it has a big impact, right? If so, how much impact do they have? Discrimination rate seems to have a big impact on mental health outcomes. Just looking at those differences between here. All right. Um, Looking at our third question, how much does intersectionality uh, impact, influence the impact of and oppression? Well, when we see here those intersections, get some guiding questions. All right. If we to explore this question, how much does intersectionality influence the impact of discrimination and oppression? One way to go about tackling this question is to ask ourselves, well, what is the rate, if one asks, what is the rate of illicit drug use among LGBTQ populations? All right. Just thinking about this question, looking from the data here, we see among lesbians, 13.8%, among bisexuals, it's 19.4%, among gays, 23.5%, among bisexual men, it's 26.7%. So, in looking at this question, what is the rate of illicit drug use? Well, there's a range, right? We're going from 13.8% to nearly double that of for bisexual men, 26.7. All right, all within this same category here. When we say what is the rate of illicit drug use among LGBTQs, it can go from 13.8% of lesbians all the way up to 26.7 per men. So looking at this question, the intersections, right? How much does intersectionality influence the impact of discrimination and oppression? Well, you see the various outcomes, right? I mean, lesbians have a lower risk, still higher than straight persons, but bisexual men growing across gender. So it really depends on the intersection, right? It's an intersection. I'm a female and lesbian, then my rate is 13. My risk is less than I'm female and bisexual, right? It's still sexual minority, but it depends on which intersection. It depends on my gender and which orientation within a sexual orientation I'm most identified with, right? So answering that question, what is the rate of illicit drug use among LGBTQ? Well, it depends on the gender sexuality intersection, right? Just from this data, it can be 13.8%, 19.4. I'm looking at men, it depends on if I'm a man or woman, and if I'm woman, if I'm lesbian, bisexual, and if I'm male, if I'm gay or bisexual. All right. It's a range, 13.8% versus all the way up to 26.7, so nearly twice. So looking at that question, how much does intersectionality influence the impact of discrimination and oppression? Looking at it, it can nearly double it. So I would just say a lot. All right. Look at our third question here. So how can we use this information? All right. What is this all telling us? Um, Twofold. All right. As a researcher, as an educator, we're always asking questions. I believe we can use this data to ask better behavior research questions, right? To ask better questions. And I say that because for many of us, for many of you, I believe this may be one of the first times we've seen data broken out in this way as it relates to substance use. Oftentimes we won't even see it by gender, right? When we're looking at, substance abuse data, sometimes even if it's broken out by male and female, very seldom, very, very seldom for myself, person who's been researching this in the field, that you'll see it broken out, not just, sometimes you'll see it broken out by male or female, and then fewer times you'll see it broken by, it'll usually be lumped all together, LGBTQ, but this actually breaks it out by lesbian, bisexual, straight. So just looking at this format, we can use this data to say, hey, when I'm doing assessments, whether it's behavioral health or any particularly behavioral health, but is there, can this extend upon other public health data and public health issues as well? Looking at the intersections, going just beyond male and female, going on just beyond LGBTQ, to actually looking at the intersections, because we see that there are vast differences. All right, so we can use this data to just ask better research questions, right? And with better questions come better interventions, right? We can design and implement better behavioral health interventions because we can figure out what is unique among this population, right? You're not going to just design a one size catch all fit substance abuse intervention. All right. So one, you can use this like, well, am I talking about any illicit drug use? Because, marijuana is gonna be, driving that. And after you get past that, intervention, am I gonna have an intervention among men, among women, among sexual minorities? And if I am, it's gonna be among lesbian and bisexual. You want to look at the intersections. What makes lesbian women unique? Why are their rates lower compared to bisexual? What puts bisexual women at such high risk? Right? You can ask those better questions so you can develop better interventions. What makes bisexual men so much higher, nearly 3 times higher of risk of hardcore substance use, cocaine, heroin, compared to straight men? Right? And once you, develop insights into those questions and insights into those answers, right, by asking the questions, you can design better interventions to help um, mitigate the issues. All right. So those are just 2 ways in which how this information can be used. You can ask better behavior research questions using the model here by SAMHSA by breaking it out beyond gender, beyond sexual orientation to actually look at the identities within sexual minorities, whether it be lesbian, bisexual, or straight, and for men, gay, bisexual, or straight. All right. All right. Well, this is a indication for me to go to switch over to my data source here. I'm gonna pull over a different screen. Um, Mac, are you able to see this? Are you seeing this Gallup website?
Yep, we're seeing the Gallup website.
Thank you, brother. Thank you. So some of you may be asking, well, why are we looking at all this data on sexual minorities, right? And I asked the same thing. First, I had to ask myself, well, if SAMHSA is looking at it, then it must be important, right? In terms of behavioral health, the Substance Use and Mental Health Services, a federal organization, if they're having a special report dedicated to substance use, to the behavioral health of sexual minorities, if they're breaking it out by this way, then it must be important. There must be a reason why. Um, you see, here's a Gallup poll for those who are just familiar with it or just, old like myself. It's one of the leading survey enterprises concerning various, information and demographics, whether it be typically goes to presidential elections and different things like that, but they do a great job of polling. So when it comes to their data, you can put a fair amount of confidence in it. So we're just gonna look. This is the URL. You can see it on screen. You can just, Google or your favorite search engine, Gallup, LGBT data, and it'll come right up for you. Gonna zoom. I'm gonna scroll down. I'm gonna zoom in and try to make the screen large. So while we're looking at this, Americans, here's one of the presentations of their poll data here. Americans, and this is recent, right? This is February of last year. Okay. American self-identification is lesbian, gay, bisexual, transgender, or something other than heterosexual. This is Gallup poll, the polling Americans. All right, see this green line here? Those are identified as LGBT. 2012, 3.5%. Most recent poll data, 7.1. All right. This is doubled within past 10 years. Okay. Bear with me while we will scroll. And looking down at it. So this is just overall US population. Okay. When we scroll down, we see by generation, we see differences. All right. Traditionalists, as they've broken it out here, those born before 1946, just less than 1% of those individuals born before 1946 identified as sexual minority or LGBT, with 92% indicating straight or heterosexual, 7% abstaining. All right. As you can see here, looking at what we call the baby boomers, those was born between 1946 and 1964, 2.6%. All right. Mac, I see we're at 2:40. I'll be wrapping this up within 5 minutes. Generation X, as they call this, 1965 to 1980, 4.2%. Millennials, I don't really refer to myself as that, but I was born right here on the cusp, 81. All right. Those individuals from my generation, born between 1981 and 1996. Okay. 1 in 10, over 1 in 10, 11%. All right. Generation Z, for those of us who teach here at Boise or any other place, these, are undergraduates here, right? These are our undergraduates. 20%, over 20%, 21%. Okay. Over 21%. Let me do the math. 20, 23. So yeah, I've got under, right within this range, 20% All right, national right classroom population identify as LGBT, and you can see the change over the years, just nearly doubled for my generation. All right, and so that's kind of providing context of why we're exploring these populations. One, from the census looking at it, it must be important. You also see the disparities within that, and also it's this population is increasing. All right, 1 in 5. Okay, I'm gonna scroll down a little bit, and it just shows that increase. Whereas this just is kind of looking at the current state, 20% of Generation Z, but it's also within those age groups how it's increasing over time. How did 2017, just within the past 5 years here, of Generation Z, those born between 1997 and 2003, how that rate doubled of those who are injured within this list themselves as LGBT. All right, let's scroll down here. All right. And again, why are we looking at, lesbian, gay, and bisexual? We see overwhelmingly that among the LGBT adults in the US, over half, right? Nearly 60% identify as bisexual. Okay. 13.9% identifies as lesbian, 20% is gay, mostly bisexual, and 10% transgender, 4% other. All right. So you can see the impact of intersections when you kind of lump all these, acronyms together, where these, make this alphabet pseudo LGBTQ, that actually there are differences within. Most of the individuals in that community identify as bisexual. And we saw that within the SAMHSA data, some of the highest risk, right? Some of the highest risk categories were among bisexual, and they represent the highest amount of the highest concentration of the LGBT community. Okay. And I'm gonna stop sharing now. I know that there was a lot to um, digest, to ingest, and gonna open it up for Q&A at this time and just general response. I thank you very much for your active attention, and I'm gonna turn back over to Mac.
Wonderful. Thank you very much, Desmond. We really appreciate it. So at this point, we are open for chat for Q&A. If you have any questions, please feel free to put them in the chat or just raise your hand, take yourself off mute, and come online and ask them. I noticed there are a couple things in here from Dana. Dana, are you interested in sort of talking a little bit about the SAMHSA data issue that you raised in the chat?
Sure. Can you guys hear me?
Yes.
Okay. I think it's interesting. And, this is just something, and thank you very much, Dr. Harris, for presenting this. I'd like to ask the group, we see that the ones that identify as bisexual are the highest. And I'm wondering on that, where the reason that everything is skewed, higher for that, is they may be perceived not only by themselves, but by others outside of them as not being one or the other. In other words, I'm gay, or I am straight, or I am transgender. I straddle, I choose to go in the middle, which means that they're going to get hit by a whole bunch of oppression that comes with, if you were a woman and you were told by a man, I'm bisexual, well, then you're not only competing with other women for that person's affections, you could possibly be competing with men. It seems to me that it would be a whole lot more pressure on those people, from both sides, of kind of like, you haven't made a choice. I would just like to know if anybody else kind of sees that as what might be, an increase in that pressure of, I'm not one or the other, I choose to be both, but that brings a tremendous amount of societal pressure on them.
It's like our brains, we share the same brain. That was one of the initial thoughts that I had as well when looking at that, as you've been pulled both ways, and when we some of the research on this that shows that what's protective for sexual minorities is having a sense of community and belonging. Right, some of the individuals, you see areas where there's more acceptance, you see lower risk of negative behavioral health outcomes. But as you can imagine, if you're there in the middle, so if you're part of the gay community, then that's one community. But I'm part of the lesbian community, that's more clear delineations. But if you're, let's say I'm a lesbian female, we saw a lot of, rates of higher substance use there. If I'm a lesbian and I have, a girlfriend who's, I'm sorry, if I'm bisexual, okay, and I have a girlfriend who's within a lesbian community, okay, and then it's, but she finds out that, also that I'm bisexual, so I've had either a current, boyfriend or perhaps relations with someone, let's just say within heterosexual community, right? Then there's a pool from this community, whether it's a girlfriend or social field, but that community, that lesbian community, and then there's also a pool from the heterosexual male community, right? And then so there's those various overlapping intersections, that can, impact each other. I definitely think that that's a reaction that I had, but without probing further, right? Doing that qualitative research, diving into these communities and asking these individuals what's behind this. And I think even before that, just making, I won't say making them aware, but I think that, those disparities were alarming to me. And I wonder within the communities, are those even well known, right? Are those well-known disparities? Is it known? Because I may ask someone like, well, why do bisexuals have higher rates of cocaine use compared to, and it's like, I didn't even know we had higher rates, right? So it's like before you even, just a bit, and I think that just it speaks to the benefit of just, breaking out the data such as this way that it can just further exploration of that kind of qualitative of the why that you indicated. But long way around of saying that I kind of had the same thoughts when I looked at it.
I'll continue. Anybody, please feel free to jump in here. I offlined with one member, and some of the reasons, we can look at oppression and things like that, but I've worked in a healthcare system that had a very marginalized population, and it was because of race. And then the gender issues were huge as well. And it's kind of an insular group that they are with. So if you are in a group where there is drug related, there's substance abuse or alcohol abuse, you're exposed to it because you're part of that group. So the question comes, which is first, the chicken and the egg? Are you in that group? That's what that group does. You're exposed to it. That means that you are more likely to be doing it in that group than if you don't identify with that group and you are outside of it. So I think it's a chicken and the egg type question, and it really will take some huge refining of research questions. And I also want to say that I think that healthcare has a tendency to sometimes, and I hate to use the word stereotype, but maybe it does apply, is I've worked in healthcare and seen how people that come in and are drug seeking are treated, and it's not good. Generally across where's the compassion, but also the pressure on the ER and things like that to not give out drugs when someone shouldn't have one. So I think that there needs to be some very serious look kind of across the continuum of why this happens. And you have to bring in outside factors like healthcare and how people are treated there and the availability of healthcare too.
You raised such, and guys, we didn't rehearse before we asked the Q&A, but it's like we're synergistic. You raised such excellent points. The chicken and the egg, and then we just talked about intersections, right? But even looking at you brought about race ethnicity, right? This is gonna, that's another, group, and then it's also by geography, right? What is it, we mentioned the how individuals may be treated within a certain location, healthcare setting within different parts of, Idaho. I currently reside within the Atlanta, Georgia area. I've been blessed because one of the few benefits of the pandemic, it allowed individuals such as myself who have a thirst and desire to teach to, be able to do so from a distance. And I'm going to try to share my screen as a person who, born on the East Coast, have lived at various different venues, who've spent some time out in Idaho and other, places with, a range of varying levels of acceptance of various cultures, substance abuse, sexual orientation, and those things, manifest, a lot of times, through policy. When you start to see something with substance use, you'll look at your harm reduction, and that's whether, needle exchange or methadone, drugs, substitution therapy, such as, methadone substituting safer drugs to get individuals off of heroin and opiates, and needle exchange or general harm reduction. You'll see those places more concentrated amongst liberal locations such as New York City and Atlanta. As I'm trying to pull this up, if I can share my screen for a second. I don't know if you guys can see this. Is that coming through, Mac? I know it's maybe kind of small. This image of this bull here.
Yeah.
Yeah, and it just this is the actual billboard, right? This is I actually passed this, when I was, driving, and then you kind of see it, no judgmental, just free HIV test. So it kind of just speaks, this is something that I don't think that you'll probably see in, I would just say, more rural or conservative environments, where you're starting to see, hey, listen, we don't care about your sexual orientation. We're not, no judgmental BS, right? Like you mentioned, Dana, from the healthcare setting, you're gonna ask about, well, how many sexual partners are you had? Are you gay? Are you lesbian? Or what? Why are you doing this? And so it's just kind of speaks to the locale. This is a billboard that's right down here, here in Atlanta. And, just Atlanta being just kind of proxy for a more urban, area where you can kind of see like, hey, no questions asked. We just want to make sure that you know your status, right? And so it just kind of gives that example versus somewhere where it could be less accepting, right? We don't see billboards, such as this. How is that going? How are those individuals going to feel? Because just seeing this as a person, with perhaps at risk of HIV, as injection drug users are, and sexual minorities are, right? They have higher risk of infectious disease, including HIV. If you see this, you may, well, this person gets it, right? This healthcare facility gets it. I'm not going to get asked a whole bunch of BS questions that are judgmental and make me feel worse about myself than I'm already, coming in here. This is putting myself in a vulnerable spot. I'm not going to feel more vulnerable by, result of just, trying to figure out my HIV status.
So Desmond, one question that I have would be, can you talk a little bit about how you see, this has been evolving, and you mentioned some generational differences, but can you talk about how you see some of these issues evolving as we, let's say, transition into a with COVID environment where it's, you mentioned some big changes that happened at the onset of COVID. We're now in a new phase where COVID has become sort of a new normal. How do you see some of the issues that you talked about sort of evolving and persisting with COVID as our new normal?
Absolutely. Great question, Mac. I hope that, well, I believe that what we saw with the data from an MMWR study, that we see the impact of stress, right? The impact that of stress and life crises can have. I really invite you and some of my other, those who've taken courses with me, that I kind of do a deeper dive with that. Overall, that study showed that 13% of the U.S. population increased their substance use as it relate from stress from COVID-19, right? 13%, just overall, just, general, but so within that, and I think that if you go to look at that study now, just put it within the, I'm sure someone can pull it up and put it within the chat, MMWR, COVID's, suicide, COVID behavioral health, you'll see it's a landmark study. But there you can see the intersections, right? That 13% was across nationally, but we actually see there are differences by race, ethnicity, and some. One of the great intersections, we actually saw this category that emerged when COVID, an unpaid caregiver, right? That was kind of an unpaid caregiver, the individuals who are caring for loved ones, right? Like if I'm a person, caring for my grandmother at home, that those intersections beyond race, ethnicity, or income, that those had some of the highest levels of substance use resulting from stress from the pandemic. And you can imagine, right? I'm caring for, for a loved one at home. I can't get out to the store to get her the supplies that she needs. I can't, or he or she, just all the things that range from the pandemic. It was unpaid caregivers, and it was also individuals who were suffering from PTSD. Those those with those kind of what we call pre-existing conditions, those who are already vulnerable, individuals who may already have underlying behavioral health issues, whether it's depression, PTSD, schizophrenia. So I just really think that, COVID has, helped explore the intersections of all the various things that we are. We're more than just a man or a woman. We're more than just Black or just white. We're more than just rural or just urban. We have a variety of different identities and intersections that COVID has, proliferated, that I would say cast a light on, that shows that, hey, we need to, ask better questions, because at the next, well, hopefully not the next, infectious disease crisis, but whenever those, such events occur, we know that who's going to be, have an insight to who's going to be most at risk.
All right, any other questions? Again, feel free to drop in the chat or raise your hand, unmute yourself. All right, so a couple of closing things here. First and foremost, thank you so much to our presenter today, Dr. Desmond Banks. We really enjoyed your talk and appreciate the time and the content here today. This was an important topic, and glad we got the chance to learn from you. As I mentioned, we did record, and we will be sharing the recording after we get it processed. There will be a feedback survey coming your way shortly after we conclude here. Please, please, please send us your feedback, your comments, positive and negative. It really helps us refine these sessions. We are still early in our process, so we need your input. We need to know how it went. So thank you very much in advance for filling out the feedback forms, positive and negative. And last but certainly not least, I'll put a plug in for our next session. And sessions for the remainder of the year here. You can see this wonderful webpage I'll drop into the chat here. The next session we have is on Tuesday, December 12th. It's on public health return on investment. We're going to be doing 2 return on investment series this academic year. So this is the first one, talking about assessing and communicating ROI. And I will actually be leading that one. So come back on December 12th and we'll do another one of these. Again, sort of some presentation from me next time, but presentation from the speaker and then some Q&A at the end. So thank you again, and look forward to continuing to share these with you throughout the rest of the academic year and beyond. Thanks again.